that okay?
I can hear you too.
Yes, thank you very much. This is my bell. Welcome everyone again. Here we are. Another wonderful afternoon. And our guest speaker is Dr. Adam Hoverman right here. Oh, yes, sure. Oh, is this good enough?
Your voice needs to be.
Oh, okay. It is with great appreciation that we, the residents of Protection Island, acknowledge this land as the unceded territory of the Nanaimo First Nation and their legacy throughout the island. Thanks to Peter, as many of you know, Rick and Emily are away or going away, and so Peter's stepped in, so thank you very much. This talk is being recorded, and Peter will let us know in a couple of days when it's available for future listening. Questions at the end, please, for the Zoomers, and use the chat box or raise your hand. Mute yourself until the end, please. Baked goodies today are by Zana, so get over there and get some. They're going quickly. Donations today will go to the Antler Swamp Restoration Committee, same as last 2 weeks ago. And I just wanted to let everyone know that 2 weeks ago, we raised $325 for the Antler Swamp. So that's really great, I think. Yeah. And so hopefully some more today. That's what I was talking to you about, Nancy, coming in her group. Yeah. Okay. So now I'd like to introduce our guest speaker. Thank you to Gerald Halibura and Nancy Hain for suggesting him. First, a bit about the topic, however. Up to 1948, the WHO definition of health was complete physical and mental well-being, not merely the absence of disease and infirmity. In 1948, however, WHO made a change to that definition to include one word, and the definition now read, complete physical, mental, and social well-being, not merely the absence of disease or infirmity. Well, the world thought about that, and they thought about that, and they thought about that for 66 years. Finally in 2014 in Norway and in 2015 in the UK, the social prescribing era was really born to address loneliness and isolation. They were called the What Matters to You movements. So socially, the question, what's the matter with you, now became what matters to you. For example, recreation scripts, caregiver scripts, pet scripts, interesting class scripts. They were non-medical sources, in other words, that help people stay healthy and that address non-medical determinants of disease like poverty and unemployment. The Surgeon General in 2023, and that's the American Surgeon General, because we don't have one apparently, Adam told me, stated that the loneliness epidemic, when looking at pathological cardiovascular immortality, is equal to smoking 15 cigarettes a day. Now, a bit about Adam. Adam was born in Columbus, Ohio. His list of accomplishments is as long as my arm, so I'm just going to highlight a few. He attended medical school at the A.T. Still University in Kirksville, Missouri. Did family medicine at the University of Minnesota. Did a second residency at the Oregon Health and Sciences University in Preventative Medicine and Public Health in Portland. Teaches at the University of Washington in the School of Public Health's Department of Health Systems and Population Health. He is in the Faculty of Medicine at UBC, where he is a clinical instructor in Nanaimo for family medicine residents. Also, he is a full-time GP at the Wellington Medical Clinic. He is the co-lead with Dr. Sandra Allison for the Nanaimo Division of Family Practice and Social Prescribing Project. He's a board member and facilitator for the Northwest Narrative Medicine Collaborative. With his partner, he is a trail runner and a poet, and he alone is a sailor with VIU Sailing Co-op. Please welcome Dr. Adam Hoverman.
Thank you, Bev.
You're welcome.
Stellar condensation of everything the the next hour and a half we'll cover. And really remarkable. The feel of the haiku shown by your hand. Yeah, bravo. Thank you, Beth. And again, thank you to Nancy and Gerald for the kind invitation nearly half a year ago now. And so many of the early conversations that we've had around literacy, I'd say are a real key underscore of this idea of social prescribing, that health literacy and understanding health and health systems is just as vital as ever, and because it's a complex, confusing language, not only medicalese, but even how to navigate through a health system, how to find health on the other side of that labyrinthine endeavor. So that's one way to also summarize the importance of this conversation and why it's a real delight to be here with you all today in that aim. So like Bev shared, the acknowledgement here is, I think, profound for the many generations since time immemorial of the stewards, caretakers of these lands and waters, and many stories worth learning from. And has been said, why ancient wisdom matters in the modern world, I think, is as pressing as ever for recognizing that many of these ideas of social prescribing are nothing new as a species on this planet. But I want to boil today's discussion down to this right here. This talk and the next hour or so of my jabbering with you all is really a collage of several talks in various settings, most recently with the family medicine residents last Thursday to ask for their help. But being that they're thick in their postgraduate training, many were like, please don't add anything else to my plate. In previous settings, through a group called Dynamic Healing, which looks at chronic pain management, that was these slides, and this talk was shared back in December with them, but they're scattered across the continent. And in between, there was a discussion along these slides thanks to the invitation from the City of Nanaimo's Accessibility and Inclusion Committee. But much more brief than we have time, the leisure, I'd say, even of today to dive into these, hopefully with a much more dialogue. Meaning there's a growing interest in social prescribing, as evidenced by the real reason I'm here, as a bit of a John the Baptist moment, is to point towards a week from today to next Sunday afternoon at the Bowen Park Complex Auditorium, the speaker event with Julia Hotz for her book, The Connection Cure. So hopefully you can just see what I'm here to share with you all today as just pointing in the direction of this, which is that connection heals, that the prescriptive power of movement, art, nature, service, and belonging. It's how you summarize social prescribing in a nutshell as it's being implemented across nearly 36 health systems across the globe. And Julie does a marvelously accessible retelling of the history, the contemporary modern history of the development of social prescribing in these many health systems, including Canada, over the last decade and a half or so, as a solutions journalist. And I feel like coming to you all here in Protection Island is just that I feel a very deep pureness of fellow solutionaries as we are here, right? What it is to bring systems thinking alongside the daily difficulties of being in these bodies and going, maybe there's more than just a pill that brings health and longevity, right? That's thinking beyond just the pill bottle and the box of the clinic. We might begin talking about what really helps long, healthy lives happen. And this book does a marvelous, not only contemporary retelling of the last decade and a half of the emergence of social prescribing globally, but also the distinct difference in the conversation between health and healthcare. I think many of you in the room recognize that there's a difference, right? And both as a family physician that then got curious about the limits of medicine, medicine and what matters in the end is the tagline to Atul Gawani's book, Being Mortal, to say that we also have a lot to look in the other systems that help keep a person healthy and well. And that's where the What Matters to You movement started, as Bev was saying, in about 2014 in Norway, and now in many health systems around the globe. If you go to the Nanaimo Regional General Hospital, you'll see many What Matters to You posters placed around, largely championed by the Health Quality BC team. Does anyone know of Health Quality BC? It's a beautiful thing to me to find that one of the things that drew me to BC is relatively unknown on a daily scale. Formerly the Patient Voices, the Patient Voices Network that is still in existence, and within the organization called the BC Patient Safety and Quality Council, seems like a good thing, right? Now known as Health Quality BC, is what is championing the What Matters to You movement across the province. As local as when you go to the hospital, you'll see What Matters to You posters. And I think it's real important just to highlight here the things that I would hope you take away from today's talk is right here summarized in this slide. Next Sunday afternoon's event, 1 o'clock if you want to show up for the Frisbee golf, 2 o'clock if you want to go for a walk in the park, but 3 o'clock if you want to be there for the Indigenous welcome and I believe even the mayor's welcome and the discussion with Julia Hotz and others, thinking about how do we put these ideas into practice. And if you could be so kind just to get the word out about the What Matters to movement. I'll talk about what that's looking like in a present quality improvement project that I have funded by Vancouver Island Health Authority that looks like these workbooks that I brought for you all today, called the What Matters to Me workbooks, that were put together by the Serious Illness Lab Serious Illness Project at the Ariadne Labs through Mass General and Harvard in Boston. Condensation of the Being Mortal book by Atul Gawande, who started the Ariadne Labs there. But really, it's a way of putting the What Matters to You question into practice. But it's a question that we say in healthcare quality and safety should be an always question, asked everywhere all the time. So you could start, maybe I'd ask you for your help today, just like the next time you're in a healthcare encounter, you could ask the person on the other side of the stethoscope what matters to you. And maybe they'll get the idea that it's also a worthy question to ask to you. Because it actually matters on both sides of the stethoscope if we're going to keep a sustainable healthcare system going, right? You got to think about what brings joy, if not love, may I say it. Avitas Donabedian talked about the love that we need for our profession, for our God, for our patient, for the work, right? And that's where we can begin looking backward and reverse engineer the system, improve the system. So I just say that this is what matters to me, and as you can see, I'm a bit passionate about it. So I'm grateful to have the chance to share that with you all in that way, condensed right here. But how did I get here is, I think, also the reason for the time and attention you're offering today, you're gifting to this space, which is to say that it's been a long journey. It hasn't been something that I was aware of overnight by going into medical school, that health and healthcare were two different things. I assumed, even by studying intentionally osteopathic medicine that I'll tell you about, that there's a direct overlap. But in fact, there's a bridge we need to build. In particular, when we think about how social well-being is a part of the definition of health, as Bev was saying from the World Health Organization in 1948. And that we need some manner of social equity to produce health. That is the caring and sharing for each other that Richard Wilkinson has written about it plenty, and books like The Spirit Level and others. That, as my mentor, Stephen Bezrushka, emergency physician from Toronto, now at the University of Washington School of Public Health, has written extensively about that politics are a key factor for helping health happen, particularly the non-medical determinants of health. And that when we talk about social determinants of health, we're actually talking about society and the context where those happen, where those events happen, the social factors and support and cohesion, I think, is uniquely protection islandist. pro-isle, I hear, is like, I sense it in the room. You are friends and neighbors, right? And so this is really where this is, I think, nothing new to you all. So please, like, we should just make a big circle and have this conversation all together at some point before we leave here today. And yet we have a Surgeon General's report from summer of 2023, as Bev mentioned, highlighting the risk factors of loneliness and social isolation that's worthy of mentioning, that's precipitating the response of social prescribing, beginning early on in the NHS, National Health Service in the UK, and now in Canada and many other places, and now really in the end, just to say, what can we all do about it? Which I'd like to point in this direction. Does anyone feel like an improver? I mean, does anyone tinker with things in their house, in their yard, in their neighborhood? Yes, right. There's like, I could sense there's tinkerers in the room. And so I'd say just the other way of offering that, when we have now an 30-some year history of needing to think about how to learn from other industries for improving the quality and safety of healthcare. That improvement and implementation science are the nerdy ways of talking about that, but it really just boils down to what it is to say shoulder to shoulder, we can co-produce health and social care. And this is from Lucas and others who published in the Health Foundation a paper and then a guide on the habits of improvers. And what I love as an English major gone into medicine, how communication is the inner ring of the donut there, right? Because it really just comes down to how we think about what we say and how we're heard, and that continuous cycle, right? Whether we're talking about literacy, whether we're talking about extreme acute environments of care, that communication is key for all manner of team-based care and improvement. And that there are just many daily habits. They kind of look like spike proteins on the outer orbit of this ring, right? But from being comfortable with conflict, to generating ideas, to team playing, to connection making, problem solving, these, what I feel should be brought to the bedside at every instance by everyone there, right? It's not that just that those wearing the stethoscope should be the improvers. It's fact, everyone who has, well, that the system has some bearing on and has some bearing on the system should be improvers in the process. It's what we call co-production. In fact, co-design is the prior element of co-production. So co-production throughout the National Health Service in the UK is just a part and parcel of daily practice, thinking that everyone who has some bearing and receives some benefit from the health system should be improvers in the process. Everyone. So this is just to go back on a little bit of a personal journey for the next few minutes, and why it feels like a real privilege and an honor to be with you all sharing these ideas today. It was what drew me into osteopathic medicine. Has anyone heard of osteopathic medicine or ever met a DO before? Or an osteopathic physician? Yeah. So it's not that common north of the 49th parallel to meet a DO, but you will, I think, more and more these days, as a former student of mine who just started practice here in town this past summer, who's an osteopathic physician like myself at Family Practice Clinic, and I'm at Wellington. DOs and MDs practice side by side in the States in all manner of subspecialties and specialties in primary care, primary healthcare settings. Largely because in 1860, there was an MD, right? It didn't take much in the day to become a practicing physician to hang a shingle in the 1860s, pre-germ theory. You know, they were mostly doing bloodletting and applying leeches, and the therapeutics at the time were largely mercurial and pretty toxic at that. And so Andrew Taylor Still and his buddy D.D. Palmer, who started chiropractic medicine. Has anyone heard of chiropractors? Right? Much more savvy businessman than his fellow friend, Dr. Still, got down to this idea that to find health should be the object of disease, to find health should be the object of the physician. Anyone can find disease. And that for osteopathic medicine in general, the body's a unit, that structure and function are interrelated, and the one I love the most, that the body is a self-healing organism. Homeostasis. That's one of the Scrabble words of the day for you. Right? These bodies, far better than any other intervention, really, that this new science, the youngest science of medicine can apply, that homeostasis, up to a limit, right? Because none of us are immortal, right? But the body, have you ever asked your skin to heal itself? Right? And that, I think, is the simplest way to point out the magic of these self-healing bodies. Magic, or just mystery, or just the biological complexity. It's just another way to say it. So drawn into osteopathic medicine because of that phrase, and thinking, yeah, I'm a fan of having a healthy, vigorous body. In my early 20s, when I was thinking about this decision about going the allopathic or the osteopathic route, I didn't yet know that there was actual definition from 1948 of health, right? Because we just assume health is just the thing that we have day to day that keeps us vibrant and alive. But in 1948, at the formation of the World Health Organization, this was defined as complete physical, mental, and social well-being, not merely the absence of disease or infirmity. A bit of an homage to that earlier quote or definition. But it really struck me as I learned this, not in medical school and not early on in residency, but that quote finally came to my awareness as I was studying global health at the University of Minnesota with colleagues in infectious disease who were thinking about our emergence of pandemics and the neglected tropical diseases that are still quite widely endemic across the planet. But it became a bit of a monkey in my back to think about where did social well-being go in our daily practice of care, because I certainly wasn't being given the tools to think about social well-being. So I say quite literally that the absence of social well-being, as I entered my early days of practice as a family physician, working for the Yakima Valley Farm Workers in Central Washington, speaking Spanish, and also going with medical students, nursing students, public health students to Ecuador and Peru to look at how do we adequately treat and ideally prevent neglected tropical diseases like Chagas, like liver fluke. Not very many safe and efficacious interventions or therapeutics for that, let alone vaccines. Really, what it takes is improved housing, education, income, right? And so that was my entry to thinking about the non-medical determinants of health through working with communities and colleagues in the ministries of health, particularly in the southeastern sweep of Peru, which gave me an understanding of the interdependence of our planet about 10, 15 years ago. But even more, going further back to my early life, what gave me this understanding was flying a lot between my parents' homes as a kid, and seeing those magazines that showed the flight paths of that particular airline's cities that they connected globally, you know, from an 8, 9, 10-year-old, gave me a complete understanding. Back when they had smoking sections in airplanes, I remember smoking sections in airplanes, right? Took a bit of advocacy from the airline stewards to get that stopped, because they were, like, as they said, locked up in tin cans at 30,000 feet, right? And the skyrocketing lung cancer rates, even in the late 80s, early 90s. But just to say that these vectors of disease, these flights, you know, like that, or just the way that it made it clear that we are an interdependent planet was evident to my imagination as a youngster. But also as the backdrop for a 2010 report, or my understanding of a 2010 report that was a 100-year look back to the early days of medical education in 1910, called the Flexner Report. That in 2010, they said, wait a second, a lot has changed. Maybe we should update medical education to the 21st century. And it was called Transformative Education to Strengthen Health Systems on an Interdependent Planet. It was a Lancet Commission report for health professionals in the 21st century. And I'll say it again, right? Transformative Education to Strengthen Health Systems on an Interdependent Planet. It really compelled me because I had no idea what any of those three phrases really meant in practice, right? At the bedside, in medical education. Transformative education, as I since have learned, and I hope there are some educators in the mix. I know Neil was sharing with me, former educator, and there's probably others, right? Came out of this idea of coming across a disorienting dilemma and then working a bit with mentorship, and then going deeply into what it is, like the Socratic method, to work in a dialectical style back to solutions, right? That's transformative education in a nutshell. Strengthening health systems, I think, are thick in the midst of that, right? In this province right now. And what compels me so much is that we have levers, clear levers in this environment to strengthen this health system. I'll tell you more about what that looks like with this project right now, this quality improvement. Quality improvement is another way of saying continuous quality improvement, as was learned from Japan, of this idea of Kaizen, is essentially the lever to strengthen the health system in this province, right, on an interdependent planet. Why not learn from other systems that live longer, healthier lives? Well, what stood out for me was that not all systems stand like bridges. And you have to sometimes work backward from failure to make sense of where we're at. And this is the I-35 bridge, August 1st, 2007, that stood over before it landed in the river that day, Between Minneapolis on the left bank of this picture and St. Paul, Minnesota on the right bank, over my favorite running route as a resident, the place that I would go for solace to clear my head after long call shifts. And my last year of residency, I wasn't able to run on this route because of this disaster, this tragedy. And it woke me up that there are clear failings of infrastructures that we assume will always exist, right? And with the 13 dead and many more injured that day, you know, that it's vital that we think about the collapse of systems and what engineers do as a part of their practice. Any engineers in the room? Structural, civil, computer engineers, right? I thought there might be. This is a wily crew. Please chime in, or at least I'll be keen to hear your thoughts on this. You know, the ring that's given at graduation, I hear, apocryphally, has a broken fragment of a collapsed bridge to remind you. Yeah, thanks for the nod and agreement. To remind the graduates on the day that systems fail, and we should always be humble and cognizant of that fact. And think about it every time a new system is beginning to be developed. So that's been my entry on a very personal and visceral scale into this idea of healthcare and improvement, healthcare quality and safety, and healthcare and improvement science at that, by having this personal experience of seeing the bridges broken pieces in that river for much of that last year that I was there. But it took about another half a decade to find a mentor who had been writing about this when thinking about life expectancy as a metric of a functioning system or a system that's producing health. It's pretty clear that life expectancy is about as specific a measure as it gets, because death certificates typically have a distance from a birth certificate and have a number of years on it on the day that they're signed. And so aggregating that data at national scale and then comparing across countries, it's quite clear that there's an opportunity to then learn from countries that have longer, healthier lives. And so Dr. Stephen Bezrushka, who I mentioned earlier, who's written about this extensively early on in an article called The Interplay of Health and Politics when looking at Japan, and how Japan in the 20th century, from August of 1946, 45, August of 1945 to the late 20th century and early 21st century, have had enormous increase in life expectancy. And so have consistently won what Dr. Bezrushka coined the health Olympics, that if health was an Olympic sport, they would repeatedly have received the gold for life expectancy. But even still, we have a lot of other countries here in that top 10, 20, right? Over there on the right between Turkey and Cuba is the country to the south of us. And here we are, there's Canada, about 16th on the list, according to the United Nations Development Report, the Human Development Report from 2024, but with 2022 data. They say here, we have about 15 countries we could look to and learn from. And in particular, the Canadian Medical Association Journal has an article from a year ago, last winter, saying we should look to those countries that have high primary care attachment, Norway being one. But there's a lot of reasons behind that, right? And there's much to say that it's not just primary care attachment. That's a good thing to have a strong primary healthcare system, but also that there's many cultural factors here as well. How many have been to Japan? Awesome. Maybe we should have a little breakout group afterwards and talk just about that, because I have yet to go. But I hear, when you can summarize it down to the idea of wa, or harmony, and all the ways that saving face and caring for each other in daily life might have a whole lot more to do with just being able to access those antihypertensives and antibiotics and you know, highly technical procedures at the time. It's also worth mentioning that I've learned that Japan's healthcare system was rebuilt by General MacArthur after the horrors and the tragedies of Hiroshima and Nagasaki. So it's essentially a healthcare system rebuilt by the U.S., right? Which is clearly not a system that produces a lot of health, as we have a declining life expectancy in the U.S. The Institute for Health Metrics and Evaluation at the University of Washington has now anticipated or forecasted by 2050 that tab there on the right-hand side will be somewhere in the 50s to 60s on this list, if not lower. So it's not just, right, healthcare, it's health and healthcare and the intersection between the two that makes a difference. So I'd like to go back a little bit further in time, but the time of this map being drawn. Does anyone recognize this river, this blue squiggly river? Maybe a city you might have taken the tube.
Is it the Thames?
The Thames. That is the Thames. Yes, this is London, circa 1860. A fairly pivotal time when it comes to talking about the history and emergence of the practice of epidemiology and public health. And in particular, there was a physician by the name of John Snow. There might be Game of Thrones fans in the audience. Not that you know nothing, Jon Snow, which I think is a bit of a poking fun at the historic Jon Snow. John Snow, who was a physician at the time, who said, wait a second, maybe it's not the air, because everyone thought in that time, there's actually a big project called the Big Stink, that it was the air, the miasma, not the water that was the spread of disease. This was pre-germ theory. Leeuwenhoek had yet to see the animalcules there underneath the microscope. Pasteur had yet to talk about what the anti-sepsis movement might be. That was another 20, 30 years at least down the line. So when thinking about how to reduce the stench, which obviously with people pouring their raw sewage into the streets and horses and other animals are defecating everywhere, and all of it running into the river, Thames, it was a pretty stinky place. So Snow began noticing patterns. Like we all notice patterns. I think patterns are just what happens with data science or epidemiology. Patterns are actually just a part of who we are as a species, right? You're like, okay, there's some clouds out there today. The wind's picked up. And you can see some whitecaps. Maybe rain's coming. We've been through this kind of weather before. But what Snow noticed as patterns were that on the right-hand side of this map, there were more deaths due to cholera. And more poverty. As many of you who may have traveled to London know that the West End has less poverty. And at that time, less deaths due to cholera. And I learned this from Trevor Hitchcock. Does anyone know Trevor Hitchcock's column in the Times columnist? He's a public health writer on a weekly basis. I highly recommend his columns. They're really helpful because it was Trevor who said these arrows also represented the flow of the Thames and the prevailing winds. So really, there's a geography inherent in most systems and patterns of disease as well. There's a climatic pattern underlying most systems of health and disease, right? Or patterns of health and disease. And so we might learn how to bring some of those skills to the present. What it led to was this, the ghost map. So John Snow, in a very novel, I'd say very relevant partnership between the handsome bearded Henry Whitehead, the beloved pastor of the Soho village, went door to door by having the trust of the Soho neighborhood, door to door, and built this map with these little tabulated, you can almost see them, little tabulated black tabs, each smallish one, representing a death due to a severe diarrhea illness at the time, would fit the case definition of cholera, not because they were looking under the microscope at the Vibrio cholera, they didn't even know it existed, right? But fit the case definition of cholera, and found that the highest number of them were in the direct vicinity of the Broad Street pump. The Broad Street pump was where most of those in that village or that neighborhood of Soho got their water. And Snow and Whitehead, with very minimal data, made their case that it was the water, not the air, and successfully argued to the town fathers at the time to remove the pump handle, and thus supposedly stop the epidemic. It's the reasoning that's been given to epidemiology students for decades now. But does anyone watch Ted Lasso? Do you remember the London sewer scene? I nearly fell off the sofa when I saw this. Here is a Apple original television show talking about what else was happening at that era. When the city was already building, with Joseph Basil Getz' direction, a huge sewer system. Hundreds of miles of sewer tunnels that were being developed at the very same time. You get the stench out of the air and the sewage out of the streets. And it's a funny thing that we still know John Snow, but not so much Basil Getz, right? For what changed the course of the cholera epidemics, multiple epidemics at the time, right? I think it's a problem we've been wrestling with still, you know. making celebrities out of the ones who get the seemingly, evident change, but maybe something else structurally was also taking shape at the very same time. I should add, I finally got to go to the pub that's right across from the Broad Street Pump this past April, thanks to going with about a dozen others from BC to attend the BMJ and Institute for Healthcare Improvements Healthcare Quality and Safety Conference in London last April. And it's quite marvelous to go to this pub that popularizes this whole story. So I highly recommend it. For the travelers in the group, the next time you're in London and visiting Soho, stop by the John Snow pub. Everything I'm saying is kind of there on the wall. It's like a museum preserved in time of this entire very relevant retelling of how just in the last 150 years, much has changed in our thinking of medicine. A lot has taken shape, though, just in the last decade and a half, pointing us towards this social prescribing era that began with the World Health Organization's Commission on the Social Determinants of Health, circa 2008, authored by Michael Marmot, now Sir Michael Marmot, who really saw that when looking at civil servants in the UK, that there is a direct linear relationship between where you are in the hierarchy of civil servitude and your life expectancy. Go figure, right? And thus authored the WHO's Commission on the Social Determinants of Health that then inspired a great many retellings of that in a wide number of settings. Is anyone familiar with the social determinants of health? Thank you. Please stop me if I'm saying something too quickly. I'm trying to speak slow and with as little amount of jargon today as possible, knowing that I'm making assumptions that much of what I'm saying is normal in some environments with healthcare folk and medical trainees or public health trainees, but not with the general public, which I think is kind of heartbreaking because it's now almost a decade. Where are we at? Almost 2 decades since. In 2011, the Department of Health of Hawaii took that report and said, let's make it local, culturally and geographically relevant. So they took this idea, this image, and some of the Hawaiian language to put it into a simple graphic that I think is worth us looking closely at. My apologies for those in the room. I'm sure those online can read it a little more easily, but I'll talk you through it. You can tell it's an image of a mountain with a waterfall and the ocean, a beach and the ocean near the front of the image. What it shows us, and down near the water's edge, is the downstream effects of illness and disease called makai, right? And if you go upstream to the top of the mountain, the top of the waterfall, you get to Mauka. Makai, Hawaiian, means water, water's edge. Mauka means mountaintop. So they use this image and these words to conceptualize the non-medical determinants of health and its impact on most of what we spend our day mopping the floor and struggling to keep pace with the increase and rise of these many chronic diseases, including diabetes, asthma, cancer, high blood pressure, heart disease, stroke. And as you can see on the shore are the risk factors for those, the traditional risk factors: smoking, physical activity, and obesity. Across the river is access to healthcare. If you go a little further up the mountain, up the waterfall, you see the realm of what I'm talking about, the non-medical determinants of health, or the social determinants of health. Discrimination, community context, geography and place, environment, poverty, education, employment, risk markers such as race, ethnicity, and age, and income and wealth, all wrapped up in the non-medical or social determinants of health. If you go to the top, those at the Department of Health for the state of Hawaii, the healthiest state of the US 50 states, right, identify that it's political context and governance and social and economic conditions that precipitate all the rest. So we have the root causes, Mauka, long, healthy lives, right there. Locally, many of these ideas were factored into that World Health Organization Commission on the Social Determinants of Health by Clyde Hertzman, who was a co-author of that report. Clyde Hertzman was at the University of British Columbia as an early childhood educator, one who helped start the centers for, or sorry, the child development centers around the province. Anyone affiliated with that or have benefited from having children receive their services? So Clyde Hertzman at UBC around early 2000s began mapping out this in the province of BC and essentially showed that, as is said, from the erection to the resurrection, that early life factors matter as much to mortality as the pathway factors. That is education. Did you graduate from high school or not graduate from college or not finish high school? Or the cumulative factors. How many cigarettes did you smoke and how many times did you get rip-roaring drunk over the course of your life? And they matter as much as the early life factors. That is the first 1,000 days, about the first 2 to 3 years of life. And now those include birth weight, who you chose your parents to be, the development, and the ecology of the setting of your early life is where more than 50% of our long-term health and well-being is programmed from the epigenetic perspective. So that's where Clyde's model here, I think, still applies in many ways when we think about the value, the role of how early life lasts a lifetime. Similar to Michael Marmot's work and Clyde Hertzman's work is the work of Julia Holt-Lunstead, who's a psychologist at Brigham Young University, who brings us a little more into kind of the heat of the moment where we're talking about the role of social well-being as well described in the literature. And that led to the Surgeon General's report in 2023. This is a 2010 PLOS Medicine article that was a meta-analysis of about 150 studies looking at about 300,000 participants, highlighting that the odds ratios for a decreased mortality were longer than almost all the other traditional risk factors when you consider the value of the social realm. Longer than the odds ratios combined of smoking, alcohol, exercise, that social relationships outpace the traditional risk factors for decreasing mortality. So a worthy thing to think about prescribing. This is almost 15 years ago now, right? In many settings, when you talk about evidence-based practice, evidence-based medicine, they say there's about a 17-year lag between a publication and when it lands in practice. And I think this moment highlights that specifically. If this is a definitive paper around what we're talking about for the foundations of social prescribing, 2010 to about 2015, maybe we have a few more years to keep pace with that average. Now, from the political science realm, a lot was written in that space by Robert Putnam, who's faculty at the Kennedy School of Government at Harvard, and wrote a book in the early 2000s called Bowling Alone that looked at the decline of participation in bowling leagues in the US. And recognized actually from an earlier bit of work called Democracy at Work, Making Democracy Work, I think is the title, where he looked at how Italy uniquely had decentralized their governance from Rome. And that the greater amount of political and community participation increased the functioning of democratic processes in the states of Italy. And he used that work to go, wait a second, what's happening in the US uniquely right now at the end of the 20th century for less participatory engagement in places like this, Lions Club, Rotary, let alone bowling leagues, all the places that people gather and have conversations like this on a rainy or somewhat rainy, soon to be rainy, Sunday afternoon. Like this is what we're doing right now is what Robert Putnam's talking about in the book. And it became a beautiful recent documentary called Join or Die that was put out in 2023. That was shown most recently, and where I got to see it was over at Simon Fraser last autumn at the Canadian Human Connection Conference, the 3rd annual Canadian Human Connection Conference, hosted by Jen Well and Simon Fraser and others at the Canadian Alliance for Social Connection Health. Showed this film, and I highly, highly recommend it. If you have access to any such streaming programs, you could watch Join or Die and get a sense of what I'm talking about. But this is like been well known and lots of sociology circles too. And so there's a medical sociologist, Nicholas Christakis, who writes about this in many books on the value of social networks and human connectedness for health and well-being. And so I highly recommend his work too. But it's just in this space of saying, even though it sounds like I'm talking about something new today, in the literature and the publications, it's at least 20 to 30 years in the making. Just building the local familiarity of that to kind of get on board with what's happening next Sunday, right? Like this is, I'm just kind of pointing in the direction of next Sunday afternoon at Bowen Park Complex, where we put this all into action. Around that same time in 2008, the British Medical Association published a report to try and get doctors paying attention to what was put into the World Health Organization's Commission on Social Determinants of Health. To say that when addressing this, what can doctors do? Essentially is non-medical. Non-medical action is required predominantly for making an impact on the health and life expectancy of individuals and community. And that's really hard, especially when you think, well, I just trained all these years, 4 + 2, 6 to 8 years of training on the average for most primary care and specialty training. Now to go the other direction and practice something non-medical, it's a little disorienting in the noggin for many. But British Medical Association was pointing that way at that time. So I was in London for a stint for something called the Diploma of Tropical Medicine and Hygiene, around the time that this was published. And I was keen on seeing what they're writing about here looks like in practice. And it was prior to social prescribing getting up and going in the National Health Service and getting condensed under what's called the Ministry of Loneliness in the UK, that brought together all these independent projects to address loneliness and social isolation across the 4 NHSs, right? England, Wales, Scotland, and North Ireland, right? So now it's well established. There's about, as I hear, there's an aim, or if not, maybe a reach of 3,000 link workers across the many NHSs, or the single NHS, to do social prescribing practice. But in 2008, that wasn't being talked about at all. But I went there to do, as I shared with you earlier, a short course in tropical medicine and hygiene, because that was my interest. I was really focused on infectious disease at the time and neglected tropical diseases at that. And in that short course on hygiene and tropical medicine at the home base where all of Snow's work kind of filtered into the training of the last 150 years of folks in the Soho neighborhood, and it's at the University College of London. One of the UCL pediatricians, Anthony Costello, came and spoke to us, and he presented this paper that changed the course of what I was thinking about at that time, just having finished family medicine, just thinking I would show up with a prescription pad and a stethoscope and, prescribe the ills away. He presented this paper where they looked at 120,000 deliveries in 5 low and middle income settings: Bangladesh, Nepal, Zambia, a few others. And they saw that simply by gathering and participating, what they call participatory women's groups, it significantly decreased infant and maternal mortality, to the tune that I didn't know anything that I had been trained to do at that point that could decrease infant and maternal mortality that rapidly, by simply finding a means to gather and do these things, right? Discuss danger signs, raise community-wide support for maternal health, organize transport, and contribute to emergency funds for transport and healthcare costs. Again, this is, to me, like a moot point to Protection Islanders. As Peter and I were talking about the work of the emergency preparedness here, and knowing Gerald's work with the fire hall and the emergency responders, the first responders here on the island, this is nothing new. You are all benefiting from these ideas on a daily basis in this very community on this island. But to me, it was revolutionary. It woke me up in an enormous way to say, how do you put that to practice back in a primary healthcare setting? So I came back to Washington State, where I was invited by the Dean of Pacific Northwest Universities of Health Sciences to present the ideas of how do you address public and population health in practice in primary care. How do you do this in the Northwest? And so began carving out curriculum for medical students, osteopathic medical students there. Around the time that this wily family physician, Byron Haney, came down, knocking on the doors of the university to say, hey, Group Health, now known as Kaiser Permanente Northwest in Seattle. Group Health has noticed that my patients who participate in these shared medical appointments are reversing their diabetes, and they want me to talk about it. He ended up going to that conference I had mentioned earlier that was in London last April. It's held every year in Orlando up until recently, the Institute for Healthcare Improvement. On his observation that similarly participatory groups of those who had a common diagnosis, by spending an hour and a half together in one-to-one visits in a group setting, in a team-based care, in an interprofessional setting with a nurse from his clinic, having this conversation, people's diabetes were dropping off the map, reversing, being cured. Go figure, right? It was astonishing to me as well. I wanted to see what it looked like, and I said, hey, can we start collaborating? Can we start finding a way to get the medical students to see what this looks like? So we got funding from a group called the Gold Humanism Foundation that had a short set of grants called Mapping the Landscape, Journeying Together. I love the title even still, right? Because all of this in improving health and healthcare is about a journey we make together. And we got 2 years to look at a similar scope and review of group medical visits, shared medical appointments in the literature. And when we got that up and going, the New York Times reached out and they said, "Hey, can we do a paper or do a column on what you're learning there?" And they came and they kind of got some images of Byron in practice at work, along with the medical students who were observing and learning what this looks like. Right? This is so much of what medical education is still. It's like, right, learning from elders, passing on through generations, trying to learn what you can do that looks like and improves upon. And really, what I learned from that work is how shared medical appointments rehumanize and even re-socialize, and then brings a humane approach, a more humane approach, identifying the humanity in the room for contemporary primary care, primary health care at that. My role during those visits was to talk about the population health piece, because I love maps. You saw how I loved all that plane travel and saw the world as an interdependent place for many years prior. So I just am drawn to maps. That's why, yesterday's opinion in the Globe and Mail, these borderlines for those on the screen, right, really, really caught my attention, right? Because I realized from all that travel early on that borders make a difference, that how those lines are decided to be drawn, whether from geographical or geological, topographical determinants, or just somebody sitting there squiggling a line across the map, really has downstream effects on these bodies because of the systems that develop therein. So this is a map. Apologies for how difficult it is to see in the room, but essentially the darker areas of the map are longer life expectancy at birth estimates, longer life expectancy estimates, right? And really pretty much the only dark blue south of the 49th parallel on the map is Hawaii, right? So that kind of is an homage to that report that they put out in 2011. But you can see how the variance looks even still across Canada, right? And the territories at that, and Nunavut at that. That says Nepal up there, right? Each of and when you look at BC, that says Luxembourg. When you look over to Quebec, that says Italy, right? Ontario, Sweden, New Brunswick, and PEI, Chile. So that's the comparison at the year this map was made to the life expectancy estimates of those countries. So hopefully it gets your mind thinking, as it did for me, as it helped for discussing with the medical students, how do we look this on at a neighborhood by neighborhood scale or a county by county scale? And so that was my role in those settings. While they would go and observe, half of the group would go and observe the group visit, and then the rest would be with me talking about the epidemiology and the public and population health of all this. And so it brought me here to get interested in our own region, deeply interested in our region. Because all of this thinking about the global aspects of comparative health system analysis, I was like, oh, there's something that I feel that happens when I come and visit colleagues at UBC and Simon Fraser, right? The ads that I don't see, the welcome that I feel, as I feel from all of you, the sense of home. Because I should mention, I forgot to mention that since I was tall enough to hold a canoe paddle and fall in love with the loons, the northern lights, and the metric system, I've been coming north of the border because stepfather's family had a place near Huntsville. Yeah, right? So maybe you know, right? So Yeah. How many have moved from east here? Yes, yeah, likewise, right? And yeah, when the mayor interviewed me, I felt a really marvelous opportunity to really get to know Nanaimo when I was looking at where to start practice here. Said most everybody you're going to meet in Nanaimo either came from the prairies or further east. And so here we are, right? Getting to figure out something from what we know from elsewhere here. And it was this map. This map kind of, along with seeing the value of shared medical appointments in practice, this map changed the entire trajectory of my career. This is life expectancy in our bioregion. That green line is Cascadia. And clearly something happens at the 49th parallel there. If darker is longer life expectancy at birth. And even in the interior, in East Kootenays and up in Bella Bella. This is a 1 year snapshot of 2012 data from the CDC and Health and StatsCan. So just a 1 year cross-sectional analysis, right? The best thing to do, here's a little epidemiology lesson for you all. The best thing that any of us can do with cross-sectional data is form hypotheses from it. Just like Snow did from recognizing that there were patterns with the prevailing winds and the water, the best thing we can do from this is form hypotheses. And any hypotheses that you might have here today to engage your noggin, your thinkers in this discussion for why we see this?
Public health insurance?
Public health insurance, yeah, the Canada Health Act, right? The Health for All Canadians and the Lawn Report, 1978. Correct me if I'm wrong, please. Yeah. Right.
Gun mortality.
Gun mortality, yes, yeah, gun-related mortality. I've seen too much of that in my career. Yeah, yeah, absolutely, and access to that. Yeah. Drugs. Yeah. What do you mean by drugs? You mean like statins and diuretics? Yes, yeah, and the toxic drug supply. Yeah, but there's this, at least in 2012. Yeah, it's an interesting distinction, right? When you think about kind of what's evolved even the last decade around the access to the toxic drug supply.
This is backing up, but I was wondering why in California, on the other map, there was a light strip right to the middle of it.
Oh,
Yeah.
sorry, because from where you are sitting, it says Germany. So the light strip is actually the name of the equivalent country with the equivalent life expectancy to that region, that state or province. Yeah, no, thanks for asking for clarification there. Yeah, right. Just like Nunavut says Nepal and Ontario says Sweden and Quebec, Italy.
Oh, around Louisiana and those
Yes.
states.
Yeah.
What are those equivalent countries?
So
can't read.
yeah, thanks.
Yeah.
I'll have to zoom in here a little bit. It's hard for me even to see. Oh my gosh, that's tiny. Can anyone online see that? Here, I'll go to another set of slides. It'll be easier for me to see here. So, come back. Oh, goodness. How do we... Oh, let me try here. There we go. Now we're back. Ooh, that is too small for my eyes to tell at the moment. So I will share the slides. Can anyone see what maybe Louisiana or Mississippi?
You can zoom in online up to 200%. So I'm trying to I don't know my US or geography. Sorry.
There's a bit of a practice of that, isn't it? Yeah. So anyway, you can tell that the Appalachia and Mississippi River valleys are lighter color on this map. That's the general gist and pattern.
And what are Ontario and Quebec there? I can't read that. I know you mentioned it.
Ontario, Sweden, equivalent to Sweden, and Quebec, Italy.
And BC.
And BC, Luxembourg. Yeah. Yeah.
I should just mention that, that we do have a PDF version of this slideshow that Adam shared with us, and so I'll send it out to anyone who wants it.
Yeah, and I'll be very keen to continue the conversation with you all after today, whoever has interest. Okay, so let's look at the t-shirt here on the left. Does anyone recognize, speaking of maps, and Newfoundland? Yeah. So I love this image, right? Has anyone seen Come From Away? That beautiful, I feel timeless musical. I went and saw it over when it was at the QE. Did anyone else go and see it at the QE back in September? Brought tears to my eyes, right? Like I grew up on the Eastern Seaboard and down east in Maine, as we say, where I went to college, and all that music is much a part of who I am. But then to see how it is a homage to a very special period when the welcome of Gander, uniquely across Canada, to those 60 some planes that landed there, and the population nearly doubled in size overnight on that day. Marvelous, marvelous retelling of that in that beautiful musical, but also, right, to then say, I think we could work on this as an idea, the Gander effect. It's actually started to be written about. Like, what does that look like? Again, this is all like making the case for social well-being and social prescribing. How do we make the Gander effect a part of daily practice in health and healthcare? I say another kind of cartoon that gives that example between the countries across the 49th parallel is just this, right? The cliff is less steep. Folks are further away from the edge, and there's greater willingness to share here, right? And for all that's been showing up in the paper in the last couple of days, right? For all of the hockey game on Thursday night, was it Thursday night?
Thursday night.
Yeah, and all that we're really grappling with, like Marlene and I were talking about here, it's at the beginning, there's a lot here that is cultural, right? There's a lot here that is set in motion over decades and centuries. And yet I feel like it's part of my driving motive is that it's possible to learn from countries that have longer, healthier lives, right? It's just who we are as humans. We can learn, we can improve. And so now in practice, what this looks like, and kind of coming to the present moment, is the emergence of what's called the Canadian Alliance for Social Connection and Health. That's an archive of the papers that have been previously and are currently being published, including social connection guidelines that my colleague and co-author, Kiefer Card, who's a social epidemiologist at Simon Fraser University, that's just about to start a medical school. Did anyone know that? Yeah, so they have 48 medical students who are going to be starting, I think, in 2026. It's going to take 4 years to get through medical school, 2 years to get through family medicine residency in order to have 48 newly minted family physicians in the province, 6 years after, so 2022, right? This is why we need all hands on deck. This is why we need Protection Island thinking, right? Like, happening everywhere all the time, all at once, right? This is like what co-production, I think, of healthcare is going to be a little more efficient than just getting more doctors minted, and because we don't fall from trees, right? We don't grow on trees, we don't fall from the sky, sorry. So that's to say that how does this set of work point us in that direction? And the Canadian Alliance for Social Connection and Health now is collaborating briskly with a group called GenWell, which hosted the 3rd annual Canadian Human Connection Conference last autumn. So these are places where this conversation is ripe and robust, along with the Canadian Institute for Social Prescribing that I'll tell you about in just a minute. All recognizing how long it took for that 1964 Surgeon General's report to lead to those red circles and cigarette images, pretty much every restaurant and bar, maybe 40 years, 50 years, right? Like I said, remembering in the 1980s, some 30 years after that Surgeon General's report, to have no smoking sections or to have no smoking on planes. I'm wondering, just suppose for your thinking, how long it's going to be before we have that similar red circle with the line through loneliness and social isolation. Right? We have a Surgeon General's report. There's more than sufficient evidence now to bring about that report. Now, how do we bring it about in practice? Right? What Vivek Murthy said in that report, thanks to Bev, summarized at the beginning, right? Given the significant health consequences of loneliness and isolation, we must prioritize building social connection the same way we have prioritized other critical public health issues such as tobacco, obesity, and substance use disorder. Okay, so now locally and present. The Canadian Institute for Social Prescribing began around 2017, 2018, as far as I'm aware, at the University of Toronto, led by some amazing energies there, champions for this work, including Kate Mulligan and Dominic Nowak. They wrote about in a 2019 Canadian Family Physician article called A Call to Action, Social Prescribing, a Call to Action. That essentially said this, that social prescribing recognizes that we have a universal need to connect with one another, and highlighted a very upcoming holiday that I hope you all join me in celebrating some way, somehow. We don't even know how it's going to take shape here in Nanaimo, but Julia's visit and everything happening next Sunday afternoon at Bowen Park Complex Auditorium is pointing towards March 19th, International Social Prescribing Day. So March 19th. Yeah, right. March 19th is the bigger celebration globally, internationally around these ideas, which we hope Nanaimo will start playing a regular presence in. And I should add, Julia has said in our conversations leading up to her visit next week that Nanaimo has uniquely rolled out the red carpet and welcome in the most vigorous of all the cities that she's done the book tour on for the Connection Cure. So something really, really, really is unique here in this regard in our local community. I'll share why in just a little bit. I share why I think that's so in just a little bit. But it's this idea of co-production, right? So the National Academies for Social Prescribing put out a report called How to Get Started with Co-Production in Social Prescribing. But essentially at the intersection, at the Venn of unmet health and well-being need or risk with activities, resources, advice or information, and active support to connect. That's where co-production of social prescribing happens. That's why I'm really here today to ask for your help. To think about how can we put this to action across our local health and healthcare system. And we have many, many, many opportunities to learn from globally. There's about 30 countries where social prescribing is enacted as we speak. And Julia summarizes beautifully in the Connection Cure. But this is the World Health Organization in partnership with the National Academies for Social Prescribing in the UK report called Social Prescribing Around the World. And it's the World Health Organization that then gave us the template here in Nanaimo to seek funding from the Ministry of Health through Shared Care to get a local pilot in Nanaimo through the Division of Family Practice implementing this WHO How to Implement Social Prescribing Guide. All right, so let's walk you through this. Here's our elder friend, but really a person of any age, ideally. Currently, it's 55 and up is where the project is focused presently, right? But I think it's evident that it should be useful and applicable across the entire life course. Arrives to the primary healthcare provider, and either through these screening tools that are showing up, St. Andrews in Scotland, UCLA, they have these screening tools, standardized screening tools for identifying loneliness, right? Not something you can measure. There's no real blood test you can test. You might correlate it with pulse and blood pressure, but I'd say the most sensitive test has been shared with me in clinic is, hey, Dr. Hoverman, I'm lonely. No more sensitive test than that, and somebody saying it outright. But there's a lot of stigma around that. And I recognize, even personally, how it feels to say I am lonely, right? And this is why we have the genre of blues. And why so much love poetry has been written, right, over the centuries, right? It is hard. It is a hard feeling to feel, let alone talk about. And this is what we're finding. It's what we're finding when I ask the question, what matters to you even? And then, nonetheless, once identified in the link worker model of social prescribing, there's a connection with a link worker. As we have here now in Nanaimo, and I hope we'll have a chance to get to meet and in future speaker series invitations. Hopefully we'll get to meet the rest of the team because there is now a wide team. I am just one person on a team of about a dozen really amazing champions for this in our community. One of which is our local link worker who is staff within community health services within Island Health, who's otherwise trained as a recreation therapist, and equivalent, the community connectors through Nanaimo Family Life Association, who now, if someone from pretty much any healthcare environment in Nanaimo can send a referral to say social prescribing link worker, and they'll be on the list. They'll be in the queue of referrals to get a phone call from either the community connectors at Nanaimo Family Life or the link worker recreation therapist from Island Health to meet up ideally for a cup of tea so that the longer conversation can be had around what matters to you. And then the opportunity to go there. Right? If they say, you know, I love ukulele, I've always wanted to play ukulele, I have dozens of Ben Ho albums at home and LPs, and I just have never had the chance to have a ukulele or go to ukulele classes, they can help. Find the ukulele, get over to Bowen Park where those ukulele classes and clubs are happening. Anyone play ukulele at Bowen? Or the many, many things that can be answered to the question of what matters to you. Whatever it is, cooking, book clubs, walks in the park, time on a boat, dinner clubs. A great many things can be answered to the question what matters to you. And a great many community organizations exist to meet that already, but a great many more can come online. When we talk about this idea of social prescribing, really what I say is we also need social pharmacists. We need social pharmacies, right? So right now we're at a point of compounding, you know, just like in the early days of compounding antibiotics, we're compounding these salves, so to speak, where that connection with the community and voluntary sector then happens with the link worker, with the community connector that goes with them ideally. So you don't feel so alone. That helps them get there even with bus passes or some manner of transportation, because that's a huge barrier, right? Here on this island, right? That goes over on the boat, right? That takes them over on the ferry, that goes with them over on the ferry to say, hey, here's my new friend, and connects them with a larger group. And then reports back to the primary care setting, right? There's a whole realm of quality improvement here that then reports back so that you could find out how it went, how it could go better next time. Did the ukulele need strings? All the many things, right? That we fine tune our practice, that we're ever improving day to day. So there's some examples here of what has led up to this moment. Literally with old school prescription pads. Family caregivers of BC that I'm closely endeared with. I champion all the time because I feel that caregiving, as has been written about by Arthur Kleinman, a Harvard psychiatrist at Harvard, who's written about in the Lancet about his caregiving journey for his wife, calls it the odyssey of becoming more human. Right? That caregiving is a moral aspect to our journey as humans. Right? Beautiful articles he writes in a major medical journal globally about caregiving for his wife. Hopefully to get other physicians thinking about them being caregivers, not only just for patients, but for the people in their lives too. So family caregivers of BC exist to that regard. There's a prescription pad that has a phone number on it and their hours of operation where there will be somebody on the other end of the line to say, hang in there. We're here to support you, but mostly it's just through having a friendly voice on the other end of the line. That many such services exist for today, but I say it still leaves a lot in the works to be able to lift up the daily needs of caregiving, right? As we know, I think even in this room. This is an exercise prescription. And in the early phase of the development of the social prescribing response or the social prescribing project here in Nanaimo, Joanne Schroeder, whose name I'd hope, if you don't know already, you get to know. She is a recreation and tourism faculty at VIU. She's also, I think, the president of the World Leisure Organization, which I think is a great name for an organization. And she's the one who's just said social prescribing is just going to be how we do business 10 years from now. She and Derek Potterico, who's a family physician, who many of you might know from Anchor Clinic, they've developed a exercise prescription program for grade 5s here in town. So that was up and going prior to our shared care project to focus on the other end of the life course. And hopefully we're going to begin bringing the streams together here, grade 5s and 55s and up, you know, playing together, paddling together, cooking together, singing together. I think that's one vision, but of many, many ways that this will further look like in practice. Maybe you've seen the article in the Nanaimo News Bulletin about the collaboration with Elder College with this idea, where I went to them and said, for the autumn speaker series, that Dr. Hector Bailey, internist, recently retired Scottish internist, lovely mentor and guide and friend in this work of what we're talking about, all things quality improvement and social prescribing, and Kamal Parmar, who's the who's the poet laureate for Nanaimo. We did a speaker series with Elder College, so got to know them well, and then kind of mocked up the family caregivers of BC prescription pads with this idea that you could write a person's name and say, hey, why don't you teach a course? I see that you're a retired chemist. I see that you have piano skills and that playing piano brings you joy, or I see that you have this great wealth of knowledge about BC history or geography or French art history, and maybe teach a course at Elder College. there. Get connected. And Elder College, I think, really exists for that. I'm hearing Robin Fisher speak at Rotary last summer is what helped put that in motion for our collaborations, because he said, this is preventive medicine. I said, you're absolutely right. Elder College is a terrific source of connection, but I'd say even in the literacy realm, when we talk about Health Link BC, does anyone know Health Link BC or 811? Great. One of the many reasons why I moved this direction was learning about Health Link BC's website that pretty much covers everything you'd ever learn in medical school and nursing school. Written mostly by, articles written about all these topics that are discussed in clinic, usually by multiple physicians, far smarter than just one. With somebody you can call 24/7 to say, hey, I'm confused by how you say that word. And now the wheels are turning slowly that maybe we should have Elder College classes that put that information into regular dialogue spaces like the speaker series. Why not, right? Like, why not make this information accessible in a classroom-like setting, not just a website? Just an idea. Another example of how I've been testing these ideas of social prescribing in practice. So somebody shared with me in this case that their friend is Bruce, the person I said, who would you go for a walk with? Who would get you off your sofa or out of your daily routine to go for a walk? And they said, well, it's Bruce. I said, well, here you go. One walk or talk with Bruce and or other friends once weekly PRM. That means as necessary in doctor speak, right? With this guy's illegible scribble, mostly illegible handwriting, but it can be that simple. And it has been. Like, we have nature prescriptions. Has anyone heard of the whole Park RX movement? That was another big motivator for me to be able to prescribe a Parks Canada pass, which here in our region is just one park on the west side, on the west coast, right? Pacific Rim. And I'm only allowed to prescribe one a month. I'm not allowed to think about or prescribe transportation there, or think would they have the clothes, or the friend to go with, right? This is where the ecology or the ecosystem of social prescribing really started to take root, when I began to see the barriers to Park RX, which is a great program. Melissa Lim and others at Canadian Association of Physicians for the Environment got up and going a couple of years ago. Awesome program, no doubt, but just still inaccessible on a daily basis, on a daily scale. So this is the flyer that's now been produced for the Division of Family Practice Social Prescribing Program, and I'll read it for those who can't see. The Social Prescribing Program helps connect patients 55 and up to non-clinical, community-based services addressing social isolation and improving health outcomes through personalized social plans and community connections. In partnership with Shared Care of BC, the City of Nanaimo, Island Health, and the Nanaimo Family Life Association. So these flyers will start to be put into clinics across the community to kind of show the foundation of this, but we're still such early days of getting it to be familiar in every clinical setting, everywhere, all the time, where this question is hopefully being asked. And I'm coming right back around full circle, keeping an eye on the time, recognizing it's kind of nap time this time of the afternoon for some, and how much I would prefer. I'm glad to offer the excuse for a nap. Some of the best well-being comes after an afternoon nap. Yeah. Next time, maybe we should get sofas here. Some bean bags and a comfier carpet.
It's been done.
Good. Let's do it again. So anyway, just coming back around to what I said at the beginning, to say this project right now that I'll summarize before wrapping up, and ask for your help and invite you as you're meandering and having discussion as we're winding up today, to take a copy of the What Matters to Me workbook that has been given loft by the Island Health Physician Quality Improvement Program, of which I'm currently in the 9th iteration of. Hector Bailey was in the 1st iteration of annual thinkers coming together from across the island, across the health authority, mostly in healthcare settings, uniquely in this case in a community setting, to then think about how do you develop in a short period of time something that's going to link up with a larger, as I said, ecosystem, in this case, all that's developing around social prescribing, as we hear about next Sunday afternoon, Bowen Park Complex Auditorium, 3 o'clock onward. And try and kind of go in the direction of where, as Wayne Gretzky said beautifully, right? Skate to where the puck is going, right? And asked why he's the best hockey player on the planet at the time, skate to where the puck is going. So I was like, well, why not go to where the pharmacists might be aware, but not given the ability to speak on identifying loneliness, right? And so in Australia, they're doing this. So there's a second-year med student at the Island Medical Program and I who are working closely right now on bringing about the distribution of the What Matters to Me workbook in partnership with the City of Nanaimo's Department of Social Planning, with Christy Wood and others there, to adapt the workbook that came out of the book Being Mortal, Medicine and What Matters in the End, written by Atul Gawande, to distribute to the pharmacies where those in my panel get their medications the most. And to learn from how they did this in Australia, to say you could start a training program, as they did, pharmacies addressing loneliness and social isolation. And we've connected, Hiran Judd is a second-year student and I, connected with Jenny Kirshner, who's the pharmacist there in Australia, to say, okay, can we look at the curriculum? Can we look at how we might apply this in BC? Can we connect with, or can you and other colleagues help connect us with pharmacies and pharmacists in BC? See if we can start there. But then going upstream, let's start with, at this point, the pharmacies that I'm connecting with to distribute these. And then in the next phase of this project, with community centers and libraries here in Nanaimo. Not necessarily at that point just for my panel, but hopefully for all of you. And I just loved how Marlene found this to begin with at the top of our gathering this afternoon and started scribbling on it. I'd invite you to do the same. To pick up a copy here as you're leaving here today and just think about, maybe it's a bit of a passport. Maybe it's a bit of a way to have a conversation with your GP or family members and around these questions: my fears and worries, my strengths, my abilities. What is your understanding of your current health situation? But the question that this particular project is focused on at the moment is the one that I love the most from kind of a philosophical bent, which is, what does a good day look like for you? That's the key question right now in this one-year short-term project. Then on February 1st, Hector, there on the left, and I went over to Save On Country Club to kind of get this first test of the project up and going by dropping about 70 copies of these off there. And we were working closely with, I love this title, Shavi, the Personal Achiever of the Year for Save On Country Club Pharmacy, right? So connect with those influencers, right? Like personal achievers, I think are good people to hang around with, and ask, what do they see, what do they know, and how to help get this further down the line. Julia, who I hope you get to meet next Sunday afternoon, Bowen Park Complex Auditorium, 3 p.m. Julia Holtz will be there to have this wider conversation across Nanaimo. But this is her Wall Street Journal opinion piece on how it might be a good idea for the incoming head of the Department of Health and Human Services, not as a panacea, and I'd want to underscore this for our discussion here today, to keep your critical thinking hats on, not as a panacea, just as a way to reconnect us to each other. Right? And even in this most vividly connected community on Protection Island, I feel like there's still other ways we could think about the ways, the interstitial ways of being connected in times when it's most needed. There's the flyer you've seen around Beacon House here today. Please take a couple as the smaller hand flyers and posters if you have places where you know they could be distributed for this week. And now I'll wind down with these last few slides. You heard me mention the Quality Forum. Quality Forum is the annual gathering of Health Quality BC, held in Vancouver every spring. It's okay. You got to take a call. That's okay. Yeah, this is good. Yeah.
Video for mother.
Oh, what are your mom? That's good. It's so good. It's just like that, right? We have the tools these days. It's just how do we use them? So I learned about this group, Nurture Development, through Cormac Russell. And maybe with the PDF of this talk, I'll share Cormac Russell's 2023 Quality Forum talk at the Health Quality of BC's, formerly the BC Patient and Safety and Quality Council's gathering called Quality Forum. Cormac, who's an Irish thinker about all things asset-based community development, presented this slide. And I feel like it's relevant to what we're talking about here today. And I hope that as we kind of transition into a Q&A session to wind down our gathering this afternoon, that this idea of alongsidership is really what this is all about. Systems that are done by us for us. Right? And in the 1,000-person attended quality forum in BC, more than half the people got up and gave him a standing ovation. Right? So at the kind of the echelons and the front line of this healthcare system, there was a lot of excitement around this idea. But now how do we bring it into the local spaces? How do we bring it into the pedestrian spaces of our communities to say alongsidership, like co-production, is needed now more than ever to help these systems, help strengthen these health systems on this interdependent planet. And so lastly, I think it's this. Mentioned it at the top, but I'll say it again. Avidis Tanabedian, Lebanese physician, public health physician, and poet, who was my mentor's mentor at the University of Michigan, said this, that ultimately the secret of quality is love. You have to love your patient, you have to love your profession, you have to love your God. If you have love, then you can work backward to monitor and improve the system. That's the key here. That's the secret sauce. That's the substance that I think draws us all here today. How do we keep that clearly in view? So there's the summary, and we all can be improvers. That loneliness and isolation are major factors impacting health everywhere, and that social prescribing is just one solution, but not a panacea. And co-production and alongsidership are key ways that we can do this together. So please feel free to reach out, stay in touch. This was, for those who don't know where Nanaimo is, in other settings, I included this, but I'm glad that you all know it well, and it's good to be a neighbor and a friend, new friend, old friend, and to turn this over to open dialogue now. Thanks for your attention.
Thank you, Adam. That was wonderful. Very, very great.
All your work so
Anyway. Questions?